everybody. Welcome to the LinkedHealth Innovation Channel. If you have not heard, LinkedHealth Innovation communities are popping up virtually everywhere. Help us stay informed, help your neighbors stay informed as we get the nation talking about healthcare. Today, we have something very special for you, a spotlight on Pensacola and a spotlight on senior care navigation. While the panelists in this webinar share insights about Pensacola, Florida, the information that they share will prove invaluable everywhere. I hope you enjoy the webinar. If you like what you hear, please follow and share LinkedHealth Innovation. Thank you again. Enjoy the webinar. Good morning, everybody, and thank you for joining. I'm going to start off with a question for everybody. What exactly is senior care navigation? If you've ever wondered who or where you need to go to help plan for a family member, a loved one, or a friend, you've come to the right place. Hi, my name is Todd Fisher, founder of LinkedHealth Innovations and LinkedHealth Pensacola. I'll be the moderator for this discussion. For more information on LinkedHealth Innovation and LinkedHealth Pensacola, please visit our website and on our social media channels on LinkedIn, Instagram, YouTube, and Twitter. Joining me today on the panel will be Angela Bottesini, Senior Director of Patient and Family Experience for Covenant Care and My Wish. Sharon Oakes, Care Navigation Expert for Assisted Living Locators, and Kerri Riggs, Licensed Clinical Social Worker and founder of CarryingHopeConsulting. Each panelist will share practical and local insights and actionable steps to become better prepared for navigating senior care options in Pensacola and our surrounding area. First, to set the stage a little bit. Navigating healthcare in any community can oftentimes be a challenge. Understanding options, access, timing, cost, quality, and so forth is in fact a full-time job. Add in any management of complex conditions, navigating senior care services, access, availability, and the like, and it's a very complex process. From knowing plan details around Medicare, Medicare Advantage, living wills, DNRs, add in family dynamics, and we all admittedly have these. This stage of life planning is difficult. In this live webinar, we will explore strategies and best practices to get ahead of some of these questions and challenges. We will look at community options and understand the continuum of care from hospital discharge through skilled nursing, home, health, and assisted living. We'll cover topics such as when is the right time to start planning? Are there people that can help you with the process? What is your first step if starting from ground zero? And the differences in types of care from routine home care, palliative care, personal care, and yes, hospice. We'll close on some insights on what to expect regarding technology use and adoption and what you should be looking for in a healthcare provider. This live session will be recorded and posted on our YouTube channel, so you can revisit and share alike. To get us started, let's do some quick introductions, starting with Angela. Angela, tell us a little bit about yourself, your background, and why this topic is so important.
Good morning, everybody, and it's such a pleasure to be with you, Todd, Kerri, and Sharon, and whoever's listening in. I am about a 35-ish-year-old nurse, RN, and this topic means everything to me for several reasons. One, almost every day I get a call from somebody in the community begging for help and guidance and direction on something that has happened acute with their family, with someone that they know. You know, by these phone calls, people are at a loss. So I also, with my own family, with younger family members, have been in this same situation, stumbling over what is the right thing to do, what's the best thing to do. So I find this to be something that each and every one of us at any age needs to look at really hard. And we need to become the experts of how we feel, what we have in our community, and what resources we can use. I've been with Covenant Care for 21 years, so I'll tell you a little later how I have some real advantages in looking through the systems and what's going on. So it's my pleasure to be here with you guys, and I'll lend anything I possibly can to help. Thanks.
Thank you, Angela. Let's go over to Sharon. Sharon?
Well, good morning to everybody. And I am a social worker of 52 years in a wide variety of things, from suicide and crisis to child protective services for 25 years. And then I found my love working with seniors. And I have a dog in this fight. I'm 74, so it affects me greatly. But I worked in hospice my last few years, and then segued into something that I had no idea what it was about. And that was working with seniors like Angela, who call me every single day saying, Sharon, they're friends of mine because they're in my age bracket. And they'll say, what do we do? Where do we go? Who can we trust? Who can we use? What are my options? And I had no idea how confusing healthcare was. And I had no idea that there were so many aspects of it. Everybody seems to know their little piece of the pie, but there's no holistic approach to this. So I set about my journey and started to learn, started to network, started to figure out where to go, how to find the right people, and which is where I am today. And I'm just doing something I love and I'm passionate about. And it's led me in other directions too, to be able to volunteer and assist in other ways. But this is pretty good. I may be 74, but I still got some good years to help.
That's awesome. Thank you for joining, Sharon. Kerri, let's finish with you. You're on mute. I can still see you on mute. You're a little mute.
Perfect. Thank you.
There you
Sorry.
go.
Gotta love technology. I tell people that's why I married IT. So my name is Kerri Riggs. I'm a licensed clinical social worker. I've been a social worker for 16 years. I got right out of school and went straight into healthcare. And it's interesting to see the journey. I never say never, because I at first started in renal and infectious disease, and then I said I never work oncology, and then I got to oncology and I fell in love with it and that population and just serving them. And then I said I would never do kids, and then I did pediatric oncology. So again, never say never. And I've worked with newborns all the way up to my oldest client was 116 years old. And so really seeing the extent of how healthcare affects all the different populations has been my life's work, I guess, and it will continue to be. I just left healthcare about a year ago and started my own private practice, just because I was seeing how people with chronic and serious illness were really struggling with mental health and coping with anxiety and depression. And unfortunately, because the healthcare system is so vast and so confusing, there wasn't a lot of clinicians in our community that had that niche understanding about the diseases that people experience and are having coping issues with, understandably so. And so with that, I decided to exit stage left, and I opened my own practice where I'm presently working for over the last year, working specifically clinical-based counseling for patients of ages 12 plus. So I'm so excited about this because my professional career had me working with, again, chronic and seriously ill, palliative care, and hospice. And just kind of like these ladies and Todd had suggested, there's so many gaps and opportunities for education. And it's like, where do we start? And so I'm so glad that Todd and LinkedHealth Innovations is starting the conversation, because I think that's the scariest bit, right? Where do I start? So thanks for having me, and I'm excited for this conversation today.
Thank you, Kerri, and thank you all for joining us as a panelist. I think we'll have some really great information to share with our audience today. So Angela, you get to kick this off. I'm gonna kind of set the stage, and then I'll ask you the question. If we lived in a perfect world, we would have senior care navigation centers that were universal, accessible, easy, perhaps not so scary, and ideally able to come to the patient and family either personally or virtually. Until that day comes, however, seniors are faced with a slew of care providers, sometimes confusing eligibility information coming out of Medicare, Medicare Advantage, TRICARE, Medicaid, and the like. Add in the differences between knowing what the difference is between personal care, home care, palliative, et cetera. And given all the uncertainties, where does Angela go? When does Angela start, either personally or through friends, to start to help a family member or loved one?
That's a lot of question, Todd, and I
Yeah, that's
love
a
it.
tough question.
Um, so just like anybody else, when you have something that has come up out of the blue, which most of the time, initially your healthcare dilemmas start as a pop on the head, you're in shock and you stumble. I have an advantage because, and this I tell you because having an advantage as a nurse and being in healthcare for all the years that I have, I've developed some incredible relationships of how you navigate the systems. What different kind of insurance covers different things. I can call up a doctor and find out who is the best for a lung cancer diagnosis in the country. I can call up someone and say, where's the best hospital for cardiac events, for cardiac surgery? The person that has not experienced a long career in healthcare does not have that advantage. Even down to things like, if you are told to go get an MRI today, most of us go where we're told to go. Go to the hospital and get an MRI. I have learned that you have to research through your insurance company. What is the best place to go get your labs, to get an MRI? What is the best place that your insurance covers? There's thousands of dollars difference between running over to an outpatient MRI place than going into a hospital setting for an MRI. Those are little things, but what happens to people that have no clue is they go where they're told, they do what they're told, and the bills start arriving. And on top of being burdened with brand new diagnosis, these incredible bills come 30 minutes after you get home from the MRI, and you don't even know what you've done. One of the things I believe, and this is easier said than done, is to know your health care upon signing up for it. Most recently, a middle-aged woman that I know called me and she said, you're not going to believe this. I just signed up for this amazing healthcare. And I thought, amazing healthcare is a juxtaposition of words. So first of all, how amazing can it be? Secondly, she said, it pays for everything but these $35 deductibles. Well, it wasn't 60 days after she signed up for that she had a huge event that required hospitalizations. It required back surgery. It required all kind of things. Well, what she didn't know about that particular insurance was that it set itself up in quarters. So you had to meet deductibles in quarter segments, not in year segments. And so she would meet a deductible, but then only for that one procedure in that one quarter, then it started over again. So I tell you that to say, to educate yourself first on your health insurance. Know what your plan covers. That is what I know to be important. And then understand what your community has to offer. Who are the specialists in your communities? If this happened to you, where would you want to go? That also goes back into living wills and making sure that documentation, and I know we'll cover that in depth, but making sure that you have a plan that you understand before you're emotionally engaged in an onset of an illness, and make sure that you have someone identified that can help guide you, attend doctor's office visits with you, and hear what's going on, because you will lose sight of all that and you need some help. So for me, I would go to the places that I knew specialized in what I had a problem with. I would talk to my insurance company as often as I could, and I would refer back to some planning that I had done previously. And this is planning that even an 18-year-old, a 20-year-old, a 30-year-old needs to do, very similar to living wills. Did that kind of cover the question?
No, it does. I think what I'll do is what I'll add before I pitch it over to you, Sharon, is one thing I would add is I would lean on your loved one, the person needing care, primary care, tremendously. I think all too often we assume they don't either have enough information. And if you're seeing a primary care or an internist that doesn't have that information, then I would be concerned. I would lean on them for a lot of advice and information around where you should be planning, how soon you should be planning. But Sharon, anything to add, and maybe share a bit about, pitfalls that you see in Pensacola regarding probably access, not just access of information, but availability and shortages and what we have in Pensacola?
I think the services are there, but it's being able to know which ones to go to, and not go to Google. Everybody goes, oh, well, they have 5 stars. And I'm going, no. They, it may not meet your needs. Networking, piggybacking on you. And I suspect, Kerri, you're the same to Angela, is you have to learn the players in all aspects, whether it's at the hospitals and it's the nurses, the case. For us, it's usually case managers, knowing who at the rehabs, knowing who provides hospice, who provides palliative care, who provides home services, but having those people and connecting everybody. I have a master book. And in that book, I have business cards of everybody that I do business with, because I can't remember all that. And so I carry it with me everywhere, because then if someone's calling me and saying, who do I call to get Medicaid? Where, which is the least expensive assisted living that will take Medicaid? Things like that. I've got it all down. And I make sure if I know that there's a training or some sort of networking group that pertains to healthcare, I'm there. And that educates me, because then it flows out. Part of this process, and I've been doing it for about 9 years now. I do it's called the Red Box, but it's wonderful because it takes you from A to Z. You get the diagnosis all the way through hospice, but explaining about what Angela was talking about, preparing, having a healthcare advocate, doing a durable power of attorney, making sure that you look at facilities, the cost. People will say, well, yeah, it's around this amount of money. They have no idea. They have price sticker shock, both for home care, assisted living, and then you get into skilled care, and it's just a nightmare. They have no idea. And so by educating others, we are helping them prepare so that they don't go through this surprise and crisis. Angela and I suspect you do too, Kerri, get crisis calls every day. Probably 5 to 6 of my calls every day are, my mom's being discharged tomorrow. I can't take care of her at home. We have steps and stairs and she falls. What do I do? And that's the kind of navigation. If we've been able to educate and prepare, then we would never have gotten to the crisis of being discharged from a rehab and no place to go and no resources. They're there in Pensacola. You just have to know somebody who knows the right ones that pertain. And healthcare is individualized. What applies to my loved one is not going to apply to yours. So it's something that is so unique. You still need that human touch. You still need a person to talk to, and someone who's got your best interests and has no dog in this fight, that has no, it isn't pertaining to their corporate greed. It's pertaining to the individual and what they want and need. And you're right about empowering seniors. Many of them need to be involved in this process. They need to be making that decision. I don't want people making decisions for me while I have the cognitive ability. So that's where we get into the education component, having workshops, training people. I do it for church groups and so on, but if we had some sort of centralized location that did these workshops ongoing to prepare people, how awesome. And then that would be accessible to everybody, not just piecemeal.
Very, very good. So, Kerri, as kind of a runway, that's awesome runway, Sharon, for planning. We don't talk about palliative care enough, and all too often it's accompanied with ultimately a terminal diagnosis. But I firmly believe that palliative care is much bigger and should start way sooner. Done right, palliative care prepares a runway, however long that is, not just to ensure the patient's getting the right care, but also provides the family adequate time to do the planning and that Sharon and Angela have talked about. I guess first for the audience, can you quickly, briefly define what palliative care is? Because most people don't know. And then what are your thoughts on that problem and opportunity?
Yeah, so palliative care is meant for anyone of any age, any stage with a chronic and serious illness. And part of what they do is symptom management. So if someone's having pain or shortness of breath or something along those lines, and they help manage the symptoms in conjunction with the patient's locus of authority. So what I mean by that is if like it's a heart condition, they're going to partner with the cardiologist. If it's a lung issue, they're going to partner with the pulmonologist, right? They don't just kind of run rampant in a different direction, really wanted to kind of build together. And then to me, the biggest piece of palliative care, the biggest benefit is helping the client and their family understand the diagnosis. So now that I have this diagnosis, what does that mean? What should I expect? How can I, increase my quality of life? How can I do things to set myself up for success? And so again, it's available for anyone, or it was designed to be available for anyone at any age and any stage. And I think what we are seeing, kind of like you alluded to, is that we're using it almost like the Jim Cantori of consultants. So if you live in Florida here, when Jim comes to our town, what does that mean? There's like a big thing coming and you're terrified, right? God bless him. But it's not meant to be that way, right? Like he's meant to tell you in advance and prepare so you can be prepared about what's about to come, right? And so that's kind of what palliative care is intended to do. An example I like to give a lot is when I worked back with a large hospital system, we worked in a cancer center, and a client with stage 2 breast cancer wanted palliative care. And understandably, the oncologist was like, no, she's totally fine. She's okay. Why are we doing this? And an amazing physician and such an advocate for his patients, and really didn't want her to feel discouraged. But the client asked for it. So of course, being a great physician, he consulted us. And we saw her, and while she was doing treatment, our medical team, our medical providers helped with the nuances of the symptom management. And then I, as the social worker, helped her as a single mom to kind of talk to our kids. Mom's not going to be the Girl Scout leader this year. Mom's going to be a little bit more tired, and this is kind of what it looks like. We also did a lot of planning, like living wills and healthcare surrogates, because, legally, who would make the decisions for her because her children are underage. And then fast forward like a year, she was in remission and we signed off. And we used to get Christmas cards from her. I don't work there anymore, so I like to think that she still sends Christmas cards. But I mean, to me, that's quintessentially what palliative care does. Now, if the disease progresses to a point where we are at a terminal stage, then there's conversations about hospice and end of life care, which is also a beautiful benefit that is significantly underutilized. Right now, we use hospice for the last hours to days of life, but that was intended to be 6 months to a year of life. So I think palliative care earlier on really helps kind of quiet the monster that is anxiety in relation to our health, and really kind of puts the client back in the driver's seat, because that's where you belong. So to me, I think you're right. I think it is something that we as a culture are really shying away from. It only kind of started in the 1970s. So if you think about medicine as a whole, we're talking about thousands of years, and you're talking about palliative care, we're talking about, the 1970s, it's still kind of in its infancy. So there's a lot of opportunity for us to kind of inform ourselves, get some additional information, and ultimately recognize that it's meant to empower us, the patient, to be heard when I'm ill, and God forbid, in the event that I'm not able to speak, my family doesn't have to question what it is that I want it to.
Yeah. So that's great. For me, I think, and to paraphrase, I liken it to the runway needed to mentally and spiritually, you can fill in the blank on where you're at as an individual, get your mind wrapped around what is happening right around that stage of life. Yeah. And I think palliative care, and for those listening, it's not 1 month, it's not 2 years, it's not 3 years, it's whatever that runway needs, that is needed for you, and obviously the condition and where you're at in life. So a huge opportunity, I think, to provide an avenue for the right care, healing of all kinds. And so, Sharon, question to you kind of in that light is, and I think of, when I think of senior care navigation, I almost liken it to when we were young and we had coaches for all of the sports we did, right? So whether you're on a baseball team or a football team, or you're a gymnast or et cetera, we had coaches. And I I like that analogy, and I wish the industry would use more of it, because as we approach perhaps the most important days of our lives, we do so a lot of times without a coach. What do we have resources in Pensacola? And obviously, besides you wonderful three people, like what, one is, and Kerri, you mentioned it from a surrogate perspective. How, are there resources? And we kind of touched on this, but how do we go about getting access to figure out who they are?
Again, there is no one-stop shopping. When I was looking at this question, I had the analogy of the kids' house, which is an entity where you do the beginning of abuse for children all the way till the healing component, and it's all in one place. I wish we had something like that, but we don't. And COVID, of course, has made this 10 times more difficult than it was. And there is no centralized area for anybody to go to do that. And it really is a matter of finding people who have that, the expertise, the right expertise, and people that, it's kind of word of mouth. It's hit and miss. And I really wish we had some sort of central area like the kids' house, but for seniors and for healthcare services. It's just worked wonders in the younger. Why can't we do it for the older? And that would be my direction. But I in terms of centralized services, I find nothing. And not in my world. I know people who are wonderful in the hospice area, people who are great. They have wonderful caregivers for in the home. They're good assisted livings. They're great with dementia, but no one that puts it all together and combines it to make it a one-stop shopping experience. Maybe the rest of you do have that, but that is not mine. Mine has been, for us, many times I have to start from point A to all the way through to hospice. We work with clients, which I'm sure all of you do too. Sometimes it's 3, 4, 5 years because the stages change as we age. So their needs change. And I never know when I pick up that phone what the need is going to be and how to direct them. Luckily, I do have that master book that will send me to where I need to go, or send them where they need to go. But I am not aware of any organized, centralized area that will tap everything from beginning to end.
Yeah, perhaps a shameless plug for, I think, why we're here, and my vision for LinkedHealth is obviously to help provide some level of glue and stickiness and knowledge about what's accessible, right? Who can we go to? Because I do believe it's a very fragmented ecosystem as far as how we navigate that. Angela, I'm going to switch gears just a little bit around the term patient experience. That term has almost become household. Part of that is because obviously, as over the past 10 years, we've become better healthcare consumers. And so as we pay for more of our healthcare, we expect more from that experience. But when you talk about complex conditions, advanced illness management, and senior care, I think all too often there's this connection of experience with outcome. And obviously, if you have a great outcome, then you can assume you're going to have a great experience, but they are not necessarily related at all. And given the fact that you have patient and family experience in your title, and the industry, probably the most challenging industry out there, home health, and then obviously end of life care with hospice, what is a successful experience for somebody needing care?
I'm going to tie this in, Todd, to a little bit of what Sharon was saying too, and lead it into the experience. In our communities right now, many of the healthcare systems are trying very hard to have an entrance point into healthcare. And by that, I mean, for Covenant as an example, and there are many other in our area, but using Covenant Care as an example, we are designed to be able to help from the beginning, which let's say the beginning would be recovery from a hip replacement. So we have home health care, and under our umbrella, we also have different therapies. We have then, as an additional resource in the community, a memory care facility. We have some private duty care. We have hospice care. We have palliative care. And I use that as an example of what we need to know about what our community resources are. I just recently changed from my family practice doctor of 38 years, who's still charted on paper and never went into any kind of an electronic system, who would sew you up in his office and see you anytime, day or night. I loved him and felt very comfortable there. But in assessing where I am in my age, what I needed for my future, I researched and found a care system here in town that I could go into through family practice, well, a DO that is set up with lots of nurse practitioners, and nurse practitioners are a great resource for us. They think like we need them to think. They help. They're the ultimate cross between a social worker and a nurse and a doctor. And then also through the same system, I could get my mammograms done. I could get my lab work done. So I made a conscious decision to leave a comfortable one dot place, knowing that I will need more in the years to come, and found a system that could help me manage that. And to that point, the technology to be able to have a portal to go in and make sure what's being ordered is done and the results are back. You have a lot of control and oversight, personal oversight. And that makes you feel a little better that you have some, I don't like the word control, but that you know what's going on. You feel confident that what is happening is being followed up and followed through. So with that, I think some of the systems in our towns all across the country are trying to do this. They're trying to add levels of continuum throughout a healthcare system. I think it's important to find that. Then to link to that is, if you don't have those great systems or people that will follow you through, I'm not sure that the outcomes, with as much as we have going on right now in healthcare, are going to be an outcome that you're comfortable with. And certainly when you're piecemealing everything that you do, every step that you do, not understanding it, you're not going to have the experience that you deserve when you're going through some of the toughest, darkest hours of our lives. Whether you're young, whether you're old, the experience ultimately affects the complete outcome, whether the outcome is good or bad, in that it's a life-ending illness or a chronic illness. The experience leading up to that sets the stage for your acceptance of what will be your future plan. I thought this through, and I put words to it, Todd, because experience is not just someone who knocks on your door, comes into your home, and you have a little cup of coffee with them. And I really like my nurse, that's what they say, and that's the end of it. You have to feel, by the healthcare experience from the start of whatever it is that's going on with you, that you have experienced people providing your care. So that means people need to tell you what makes them the best person to care for you. You want to know what it is. What is their credentials? I want to know that I've got the best nurse that has done 1,000 sticks before they put me to sleep, and that they have had success rates that are amazing. I need to know that. I also need to feel valued. I need for them to hear what it is, my fear, my concern, what I don't know. I need someone that is caring for me in this way to understand my fears and what I need to hear. I need honesty. I need empathy. I don't need you to tell me something that's not true. I just need you to care enough to look at me and be with me and walk with me and give me solid, good information. And if you don't know that, help me to the next person. I need a Sharon and a Kerri to take me to the people that know what I need to know. Even if the outcomes are not good, and even if there are glitches in the care along the way, if you have that relationship with those healthcare providers, it is a lot easier to feel confident that they're going to make it right. Yeah. And that they're going to make sure that you are in the right space, and that eventually, whatever the outcomes are, everybody's got your best interest at heart. So education, honest dialogue, managing up the person that is with you and going to provide care to you. I want to know what makes you all that great or different. And then open dialogue and being available. And I think as an experience, that overlay onto any doctor's office, any kind of procedures, anything that you need, that experience sets the stage. Or it can turn everything into a really, really bad, chaotic experience.
Well, again, to summarize, so, you are the proverbial you. We are our own biggest impact to our patient experience. And your explanation there, I just had an epiphany, an idea, is that perhaps we should take the tact of actually writing out write it out on a piece of paper, a contract, if you will, between you that expresses how you believe you think this experience should be, and give it to your caregiver, right? No one does that. I mean, they go verbally and they say, I've asked 1,000 times, et cetera, whether you're in acute care or regardless of the care setting. But it just dawned on me, there's a lot of gravity when somebody hands something and sounds silly, puts it on paper. Write down your expectations on paper, make a copy of it, give it to the nurse, give it to the aide, give it to your doctor, give it to whoever is providing and is in charge of giving you care. I believe that'll go a long way at helping them realize the gravity of what it is they're providing.
Well, and I just said something, I just pontificated what I would think everybody would think would be, and what I use to judge a good experience. You're absolutely right. There are different cultures. There are different genders that all would see this very differently. I think the core value is like the golden rule, but I think you're right. That is a brilliant idea. If we could have just that kind of, even if it's not a dialogue, if it's here, would you mind taking a day or two on my next visit, fill this out and let's get back together. That would be so awesome with even a doctor's office or any system.
So Kerri,
what a good idea.
Yeah. And so it's gonna take me to my next question. I think as possibly no silver bullets given this question, and I'm going to throw you a tough one. There's really no easy answer, and I don't believe we'll settle on one today for the audience, but I think it's one that deserves airtime. Obviously, given some of the disparities that we have across economic situations, ethnicity, race, et cetera, accessibility, acceptability. How do we start to approach some of the health equity issues in some of our populations that just aren't getting care at all when it comes to this level of care? And comes back to that answer. I think it would benefit them to write something down as well, right? But again, not a silver bullet. I guess, briefly opine on what you see in that area.
Yeah, I think, there's so much opportunity from a macro and meso level, right? Like, so from our government to healthcare and insurance in general, like opportunities to make it more accessible and equal. I mean, we're still finding that some of the standards for heart health are actually based on male research participants rather than female research participants. We're still recognizing that a lot of the standards that we have in relation to a lot of different diseases is related to specific race versus all races. And so I could spend days talking about the opportunities that we have to kind of level the playing field, so to speak. But I think from a micro level, so from the patient experience level, what is it that I can control? Because a lot of stuff feels so exceptionally out of control. And we do live in a very, at least here in Pensacola, it's one of the lowest socioeconomic areas and communities in our state, and also low literacy. So what does that mean? Access to healthcare is exceptionally challenging. I remember being consulted multiple times for someone who was labeled non-adherent, so not doing what the doctor said. And when I went to the room, it wasn't like this person didn't want to do what the doctor said. It was literally a matter of, do I pay for food or do I pay for wound care supplies, right? So we're not talking about this desire to just be flippant about my health. It's quite honestly, the accessibility of resources is not such that is available. And then to all of us, like being to say to a doctor, it's, it's not me just being, non-adherent, it's me not being able to afford this thing that you're offering is such a hard conversation. I mean, I remember being younger and newlyweds, and we rice and beans and rice, right? So like to have to go up to someone and say, I can't afford this is really embarrassing and really challenging to have. And so then you sometimes experience a little adversary at the doctor's office. Oh, well, Kerri never does anything that I tell her to, just right. So then we're having this kind of feeling, and then it requires me to not want to go anymore, right? Like I don't want to be accepted by, like I don't feel accepted by this person. I don't feel accepted by my healthcare provider. So why am I going in the first place, right? And so from a patient level, I guess the biggest thing that I would strongly encourage, as hard as and embarrassing as it might feel, is to be so exceptionally honest with your provider. I want to do that. Accessibility to that is really challenging to me. You prescribed me this medication. The copay is $20. I'm literally overdrafted in my bank account by 30. I can't pay for it and I want to. And that level of transparency, I know I've seen it in healthcare, because when I responded to the doctor that this person just couldn't afford it, bless his heart, he went and like bought it, which we're not going to say whether or not that was right or wrong, but I just mean like the heart and passion. I'm not saying you should expect that, but the level of transparency, vulnerability, and trust that really took for that patient to tell me, for me to tell the doctor, to then be able to change it. And quite honestly, we did a much more sustainable solution. I contacted the insurance company. We got an authorization. I contacted the pharmaceutical company, and we got a grant covered for that medication for a year. So this client wouldn't have to worry about blood clots. Like this is not someone wants to flippantly not do, right? And so I guess to boil it all down, the vulnerability that it requires, I know is huge, but I think it is necessary to trust that information with your provider. And kind of like we were talking about earlier, right, with Angela and Todd, like this is the things that I need to outline to my provider that I require from you. But being able to give that level of transparency allows the other people in the system. So like Angela was talking about, there's a system. I know the doctor doesn't know that there's an insurance or a medication pharmaceutical grant, but I, as a social worker, right? Sharon, as a social worker in the building, would be able to know that and work on that with you. So I guess what boils it all down, and like you said, there's not a silver bullet, and there's so many different layers to this, but I think the number one thing that a patient level or a caregiver of a patient could do is that level of transparency to say, it's not that I don't want to be adherent. It's that I really, really encounter barriers to care. And I need you to understand where the perspective I'm coming from. So potentially we can get an alternate medication, or maybe look at a grant or other resources that might be available. So I know that's a real boiled down answer, but I feel like that's the most tractionable thing for most of us to do.
No, that's a really, really good answer. And I'm going to perhaps throw a jump ball to Sharon, you and Angela, as I know we're close to coming up on the hour. So much of that, I think, transparency has to come. Unfortunately, we all get to a point where we have an acute event, right? That probably sends us to the hospital, which brings up, while we're in the hospital receiving care, all of that obviously is extremely important. But the discharge planning process is so key. And I don't think people of any means, regardless of where you're at in the economic or the spectrum, I don't believe people realize how much transparency they should share with discharge planning, but also how ingrained they should be in discharge planning. So many times people wait for the discharge paperwork, and of course they maybe have talked to the hospitalist, and then if you're end-stage renal disease, the nephrologist, but like all of that is just blurry to the patient and family. How ingrained? So question, how ingrained should somebody be in the discharge planning process when you're
Oh my
leaving
goodness.
a hospital?
I think people are under the misnomer that the poor case managers at the hospital can possibly address all their needs and know what is available for them. They don't know which assisted living or should they go home with care, that kind of thing. There's some primary decisions that can be made, but the family or whoever that healthcare surrogate is needs to absolutely be involved. And one of the beautiful things that I like, and you mentioned it, listen, both Kerri and Angela, that's what we need to be doing, because it isn't just about what the hospital says. It's also about what the person says. Can they afford it? If not, what is the truth? What is the viability of this option for them? And so from a hospital discharge, I encourage everybody to please stay 3 nights in a hospital so you can stall, go to rehab, and then that'll give us more time to be able to see what is available. But I love being able to personally go out to the hospital, to a rehab, to a home, whatever, and find out what is needed. And sometimes we have to do a reality check. Adult child thinks that mom with advanced memory disease can be left home alone with a stove and she wanders and so on. So we have to do that explanation with the family, but that can be done at discharge planning. And many of the caseworkers at the hospitals, many of them in the rehab say, Sharon, can you please come meet with this patient? And that's to help with the family, because I try to meet with the family too, but that's what we all need to be doing. And it's nice because they can hand it off and then I can work with what they can afford. It's better to be told the truth. People think, oh, Medicare will pay for this, Medicaid will pay for that. No, they won't. And I would much rather tell them the truth so we can have a plan B. And that's what's not happening. They're just giving people in the hospitals, they're giving people a list of places and they have no idea. They have no idea of cost or capability or availability, any of that. And, this is their loved one and this is personal. And people forget that. It becomes so clinical and you're so overwhelmed with whatever your role is in the hospital or even in the rehabs. It becomes a numbers game and just getting people out. And it's not that people are, they don't mean to be that way, but it's just a matter of being overwhelmed with all the seniors that are out there that need this help. And sometimes it's not even seniors. We have a lot of people that need help with traumatic brain injury. They've been in the war, had a motorcycle accident. So we have a lot of younger people, but please, 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 having a personal relationship with the hospital, case managers, case workers, the rehabs, and then being able to explain so people know what their options are. And that's what we've been really successful. It's so nice that it doesn't cost anybody anything. We just run out to wherever they are and we try and figure it out. But the key is we tell the truth. And if they can't afford it, they can't afford it. And there are very few resources. Like, it's nice with the insurance companies if you can go to bat with them for the medications, but you can't go to bat with them with any of the assisted livings. And most of your assistance in the home is private pay now. It's money, money, money. And we have become such a commodity as seniors for monetary benefit that we've lost sight of who we're serving.
So Angela, I like this topic and we'll jump to the next one to close out in a second, but I think I'd like to hear from you. I think our audience would like to hear from you. How, I guess, make sure everyone's aware, discharge planning all too often they think that it happens on the last day, the last day. Discharge planning, actually, if done right by both the provider as well as the family or loved one, starts on the day of admitted into the hospital, right? The sooner you do that, the sooner you start to I think adequately plan.
It does. And it's interesting because I remember when the shift happened probably 25 years ago, because discharge planning was not as aggressive as it is now. You had a sweet, lovely social worker that would spend time with you and there was no rush. And then the case manager would come in and take on the medical side of things. And then your own private doctor who made rounds in the hospital would come in and help. And so the 3 people would come up with a really soft handoff. And the day that the hospitalist basically came into the system and our private physicians were no longer making rounds, changed a great dynamic because those personal physicians knew us and knew a lot more about the truths of where we were socioeconomically and all those things. So they're out of the picture, and now someone that you've never seen or never will see again is actually there. And so the case manager is put into on day one to having that conversation of what's going to be the outcome when we can get you well enough to get you home as quickly as possible. I get many calls from people saying, and it's horrifying, but they just have to be educated, that the case manager just came in and they're going to discharge mom in the morning and we're not prepared. Well, back to what Sharon was saying is communication, because you can say to that case manager, if you are empowered and feel confident and comfortable, I'm not prepared, so we're going to need to work on this together, and it may take longer. I can't, I won't. There's some things that you can firmly say if you're not capable to take someone home at that point in time, to extend that dialogue to get a better outcome. We as an American culture, if a doctor or someone in a white coat says anything to us, we nod our head and say, okay, whatever we need to do, we got it, we'll do it, whatever. And then we crumble. And so I think now, with readmits to the hospital being a crucial point of success for the hospital setting, that we are able to have better dialogue with discharge planners. I would say that is your person to say, these are my obstacles. I need this help. And I'll tell you, all know this, it is a very few people in this town or many towns that can afford to pay private duty to come to the home and take care of people, when in fact, even the private duty in our area does not include nursing care. Right. We don't have registered nurses that go, you can't pay any price for that. So then there has to be the link to make sure that all those holes are filled to make for a successful release. We need about 2 more excuse me, weeks to discuss this, because it is something to behold. And if as you were saying, Kerri, our area and our communities, we have some very poor communities that live in poverty in ways that should only be in a third world country. And those are the folks that need information and need guidance and need help as well, because they have no idea how to maneuver or manipulate, as a negative word, the healthcare system for their only benefit.
Yeah.
So I don't know, Todd.
Yeah, we need to, quote unquote, get talking, I think, across not just Pensacola, but all communities. I'm going to paraphrase this last question a little bit and get some short answers. And I bring it up only because I think since COVID, we saw a more rapid use of technology across all settings of care. And perhaps the tail end of COVID, in the middle of COVID, there's a negative perception as we had loved ones sitting outside of windows FaceTiming, right? Because they weren't able to have access to care. And I think that perhaps, at least in some people's minds, gave a bad impression of the use of technology. I think technology and its use of care is here to stay, and I think it's a huge value add. I'm curious what you are seeing out there, again, to be short in your answers, but are you seeing providers use technology correctly? Short answer. I'll go to you, Kerri, first, and I'll go around the horn.
Correctly, that's an interesting pivot to the question, but at the same, I mean, I would think yes. I think the accessibility to care really is essential for a lot of reasons. We live in a rural area. I know in my own private practice, I have telehealth available for clients, and that's really helped with accessibility. Like when I'm out of town, if something like a crisis happens, I want to be available to them, right? And so I'm still able to access them to be able to provide the care. Now, I mean, is there an opportunity for people to abuse the privilege? Potentially. Have I seen that in our community? No, honestly, I think there's still a significant underutilization of the technology, because it does allow clients to get access to care much swifter, and also kind of takes out some of the complications that some people have, like transportation, right? That is a big issue in our community, transportation to care. So I have not seen anyone use it inappropriately. Is there an opportunity for people to misuse it or maybe rely too heavily on it? Yeah, there's potential there. But I think what I found and seen recently, particularly since COVID and after COVID, that it really enhances the care. And quite honestly, we have a lot more opportunity to engage. And while a lot of people I hear say, oh, seniors don't like to use technology together, I can't tell you how many people's homes I went into when I worked in with Covenant and we were deploying devices, and they were better than the young ones. I mean, they just really clicked into it, enjoyed being able to access like a human being when necessary. And so I think a lot of times when I see providers really hesitant, it's because of the population they serve and what they assume of that population versus giving them the opportunity to learn and honestly lean in. And I've seen such success in that in real time.
So Sharon, maybe closing with you before I close. Obviously, you're closest to the assisted living. I guess you saw it probably firsthand coming out of COVID. What's your take on that?
Oh, it's been wonderful in the sense of being able to have a son or daughter in another state who is the power of attorney sign a document, being able to DocuSign, do all the paperwork, do the Zoom assessment. Say, I have a lady right now in New Jersey, and do a Zoom assessment, health assessment there of her to make sure that she's appropriate to come down here to Florida. So in that, technology is amazing, and it has really expedited placement so people can get a place to live faster. But I have to end my comment with that nothing will ever replace a human touch, ever. You need that handheld, you need a hug, you need a face-to-face, you need a smile. So
no, that's awesome feedback. And before I close, we do have one question, a few questions, but I think the one that's probably most pertinent to answer it in time, it's a good one. Does everyone have access to a social worker? Simple question.
So I will tell you, when I worked in the hospital, there is a social worker on call.
Okay.
And I would get every community call that week. So I have not been in a hospital. I'm not going to, I'm going to be transparent, for about 8 years, but I do know that they are still on call. Is that going to be your personal social worker to navigate all the things? No, things, like what Todd and LinkedHealth Innovations is doing, I think is really exceptionally needed in our area, and might have the opportunity eventually to have something like that. But I will tell you, there is such a thing as like phone a social worker. And you could do that. I would recommend with your local hospital if it's related to healthcare, because there is social workers on call. Insider information. How about that?
Thank you. So I know we're at time, and Kerri, I know you have a hard stop. I want to thank all of you, Angela, Sharon, Kerri. You guys are a tremendous asset to our local community. The patients and families that you guys touch are truly blessed, and wish we could spread you across the whole Pensacola wide area. In closing, this webinar has been brought to you by LinkedHealth Innovation. We are on a mission to get communities talking, to unify a health and wellness narrative really across the country, because I believe not just within Pensacola, but we have opportunities to share what other communities are doing well as well. And I don't think there's enough of that connectivity happening in healthcare. And so hopefully this live event got you thinking, gets you asking questions, and gets you talking. Again, thank everyone for attending. The video will be posted on our YouTube channel with Kerri, Sharon, and Angela's contact information for them and their organization should you need their assistance. And again, thank you everyone for joining, and everyone have a wonderful, blessed day.